Good afternoon and welcome to HIT Policy and Blockchain Update, a webinar tweet chat combo from healthsystemcio.com. Just a little housekeeping before we get started. My name is Anthony Guerra. I am the Editor-in-Chief of Health Systems CIO, and I will be your moderator today. We are having a simultaneous tweet chat hosted by Kate Gamble, our Managing Editor and Director of Social Media. You can participate in a separate browser or on your phone by using the hashtag HSCIOchat, or you can simply view the tweet chat in the Media Viewer panel on the right-hand side of your screen. We'll also be using the Q&A panel today. You can send in your questions as they occur to you and leave the default set to all panelists, and we'll take those later in the program. And you can download the deck by using the URL on your screen. It's been sent out in the chat box, and it's at the bottom of our slides. Just so you see how we're going to spend our time today, first we're going to have our featured presentation from Dr. John Halamka, Executive Director of the Health Technology Exploration Center at Beth Israel Lahey Health, and then we will have our Q&A. So, without any further delay, we're going to turn it over to our good friend, Dr. John Halamka. Dr. Halamka, thanks for coming. Thanks for being here today.
Well, absolutely, and very happy to join. So as Anthony said, on March 1st, after 23 years as a CIO, in this merger of the Beth Israel and Lahey, felt that the next 20 years should be spent mentoring those who will replace me, investigating those technologies that emerge in our industry that will fundamentally change provider, patient, payer, and pharma experiences. So at this point, I now, for 26 days, have led the innovation side of the Beth Israel Lahey merged entity. And part of that is continuing my work on government relations and understanding policy. What we have in today's update is really the most important policy update that we've seen in a long time, and that is the ONC and CMS Notices of Proposed Rulemaking from February 11th. So, Anthony, let's go to the next slide, the ONC and CMS Updates. And I'm going to give you some high-level themes, and we'll drill down to each of those Notices of Proposed Rulemaking. This is some 800 pages of very dense material with lots of interesting policy implications for both providers and payers. Now, one thing you should realize is a Notice of Proposed Rulemaking isn't a rule. It's a proposal for a rule, which goes through a comment period, goes through revision, and then you can, I'm guessing, expect in third to fourth quarter of 2019 the final rules to be promulgated. And my experience with these rules in the past is about 90% of what's in the proposal makes it to the final rule. But there are some elements of controversy that we'll talk through, especially some of the timelines for implementation of some of the new capability. So what did we see in these rules? Remember, February 11th, 2019 was the middle of HIMSS. And Seema Verma, Mike Levitt, a variety of folks who are in Washington or have been in Washington took the stage to talk about things like patient-directed interoperability, patients as data stewards. So these ONC and CMS rules are very heavy on the patients getting access to all their data. And by all their data, I mean not only their clinical data, but I also mean their financial data and claims. And this is a bit novel. What you see is that the standards focus on not just the term APIs, because that's what we've seen in some previous NPRMs and regulations. They actually enumerate the FHIR standard and Argonaut implementation guides. So we're getting more and more granular about the idea that providers and payers will have APIs for patients and their apps and their services to gather data. In the past, of course, many hospitals, especially those who go from fee-for-service to value-based purchasing, have started to do ADT exchange. So, Anthony, let's just make this up. You are my patient, and I see you in my risk-based, value-based purchasing funded plan at Beth Israel Lahey Health. And you decide to go to a super expensive hospital across town. Well, you know that I'm now completely responsible for every dollar of cost you incur. I actually really want to know whether or not you're in my system or outside of my system. And maybe if you go to a place that isn't the highest quality or isn't a reasonable cost, I'll want to try to get you to a better setting of care. So part of these rules say hospitals must now send the admit, discharge, and transfer data across the continuum of ACOs and participating organizations managing wellness so that we can coordinate care better. And that's never been a proviso before. It's a must, not a might. Payers have to get involved as well. Now, Medicare, of course, has been early in adopting the Blue Button 2.0 FHIR-based approach and a whole variety of connect-a-thons and data paloozas. But now every payer must provide the patient access to the FHIR-based claims data using the Blue Button 2.0 standard. And so that means we're going to see a huge ecosystem of new apps evolve where entrepreneurs are going to offer value-added services to patients, and with the patients getting access to their data from payers as well as providers, we'll have some really interesting and unique guidance, navigation tools, and things that will help patients and families hopefully stay healthy in their homes at lower cost. You must, as part of the federal government, CMS's regulatory authority over Medicare Advantage, Medicaid, the children's insurance plans, qualified health plans, CMS can say, yes, claims data must be exchanged. And here's another really important point. You remember when Meaningful Use Stage 1 and 2 said you must exchange these CCDAs, these XML forms, across various provider organizations, but we had no directory of the endpoints, the direct addresses of all of our various individual providers or clinics or hospitals. So in effect, Anthony was like, you must drive, but we're not going to build you any roads, and there is no Google Maps. Okay, how do I get there? Good luck. So now CMS, as part of the NPI system, will be providing a provider directory with electronic endpoint addresses. And here's how they're going to do that. It's fascinating. They're going to shame every provider in the country into doing it because they'll say, please update your NPI to include your electronic endpoint. And if you don't, we're going to publish a wall of shame of all those providers who failed to do so. So can you imagine how embarrassing it would be for your healthcare system to be on a wall of shame saying you aren't interested in sharing data and coordinating care and reducing costs? It's going to be a pretty interesting way to affect change. So let's go to the ONC updates. That's the next slide, Anthony. So the ONC updates have some interesting provisions around information blocking and reducing friction. So one element of friction in the past has been transaction fees, click charges, subscription rates that are high. And interoperability, even if technically possible, isn't going to be adopted if it's too expensive. So what ONC says in this 800-page rule is there are strict limitations as to what vendors can charge as part of a health information exchange. So that is, if you are deemed, and the definition of health information network or health information exchange is extremely broad. So if you fall under that umbrella, basically you can recoup your development costs, but you can't charge ongoing connection fees or charge patients at all. And so that's going to be fascinating because really in two respects. The EHRs of America will have to provide these APIs for various purposes and will be very limited in the fees associated with those APIs, and the patients can never be charged. But I expect as you're going to see these entrepreneurial new apps and new services, they're going to probably want to charge something. I mean, right? There would be no motivation to provide a new app or service if you couldn't charge for it. So they'll have to carefully classify their companies as not health information networks, as suggested by the ONC definition, so that they have the ability to charge some fees for value-added services. So there you go. It's create APIs, reduce friction, limits what an EHR vendor can charge, and ensures that the patients can get to this data fluidly without charge. And provider organizations in 2020, I mean, pretty near term, are going to have to make sure these APIs are readily available. There's some promoting interoperability rule work that has to be done in 2019, but by 2020, all these APIs for payers and providers are going to be required. We talk about the NPRM potentially getting some pushback. One bit of pushback might be the deadline. There are a lot of provider organizations, I think of my colleagues in Medicaid, for which putting APIs on top of existing legacy systems is going to be really hard. And doing it by 2020 could be impossible. So we might see that in the final rule, there's a bit more of an incremental approach to adoption with potentially some extended milestone dates. And information blocking. So Anthony, what have you seen in your role as editor with information blocking? Technology problems or psychiatry problems? The idea that a competitor is going to get access to your data feels a little uncomfortable, doesn't it? Or what if you have to invest a substantial amount of technology and it's going to be for the benefit of society, but then there's a privacy breach and you bear the fine? So I think what we've seen in the past, not so much technology, but psychiatry, that he who invests in novel technology isn't necessarily the beneficiary of that technology and may very well be susceptible to fines if the technology goes awry. And so the ONC rule very carefully and thoughtfully says this is what you must do. Share data for a variety of purposes with a very few exceptions that will be and I think pretty reasonable exceptions for not sharing data. And let's just come up with a couple of exceptions that would be part of this sort of 7 exceptions they outline. Now, I've forgotten, Anthony, have you ever had adolescent children?
Not yet. They're 7 and 9.
Okay, well, wait till you get an adolescent child. And then you have the following quandary, which is today at a 7 and 9-year-old, I think we could easily argue they shouldn't have a portal or a PHR or an app for management of their own health care at 7 and 9. You should be a navigator who works with them. But imagine that your child is now, 15, and let's make this up. The child goes into a primary care doctor for contraceptive counseling. What should we, as a matter of policy, do with that data? Should we say, we must share data from all notes and all visits for all people with, parents until the age of 18? Well, you can understand how some hospitals or doctor's offices may say something like, below 13, you don't get a PHR. The parents navigate your health care. Between 13 and 16, there'll be a dual role. The parents will have access to most data, but potentially a person 13 to 16 could have access to some data the parents don't have access to. And above the age of 16, then the person gets access to their data fully and the parent doesn't. Or I made that, of course, up, but you can understand how a thoughtful policy like that might be totally reasonable. And therefore, it's not information blocking to prevent a patient from reading about their 15-year-old's contraceptive counseling. And so this is in the enumeration of the exceptions. If things like economic hardship or technical difficulty or protecting of a patient's privacy rights, that would be reasonable exceptions to the rule forcing a ubiquitous API access to all data. Totally thoughtful in my regard. And so here, let me give you another example of what I mean by economic hardship. I'm in the Commonwealth of Massachusetts. Suppose a 2-doctor practice in Guam says, I really need a full API access to your patients. And I say, well, we sent one patient to Guam in the last 25 years. It's not that we're in any way reluctant to do it from a policy perspective, But the economics of focusing on Guam when I have 1 million projects in the Commonwealth ahead of it is that we'll just probably never get to it. So that might be a hardship exemption simply because it is not aligned with any business incentive or a large population impact. And so if you, however, say you're going to block just because you don't like your competition, then there will be fines. And the OIG will come knocking on your door and will ensure that you are sharing data for care coordination in your community as long as you are doing it, taking into account patient privacy and these sorts of things. So that's the ONC update. Now let's look at CMS. So why don't you go to the next slide.
Okay.
And so, as we talked about, CMS is going to take the lead in providing a centralized provider directory of addresses, these direct addresses. And you might imagine as we get to APIs and FHIR endpoints, they're providing universal resource identifiers, URIs or URLs to get at these APIs. So that's a great development, really, and I applaud that idea. And I talked about the shaming of providers who don't do this, and the fact that all hospitals will now need to participate in ADT exchange to coordinate care. All very good. Now, there's some other interesting aspects to the rule. In the Clinton administration, remember, the president signed an executive order, even though we had HIPAA in 1996, requiring us to develop eventually a universal patient ID. You saw these budgetary restrictions that started in the Clinton era preventing HHS from implementing this universal patient identifier because there was some concern that there may be some privacy implications of tracking all your data with a universal number, and what if that universal number is lost or stolen or leaked, and might you very well see bad actors getting at your information without your consent because it's linked to a universal identifier that you have. Sort of akin to identity theft of Social Security numbers. So HHS doesn't have a budget for encouraging a national patient matching strategy. However, in this NPRM, there's a fascinating workaround, which says, well, although HHS can't do it and can't pay for it, HHS can absolutely encourage private industry by providing enabling policy or providing encouragement, communication, convening. So in this reg, you'll see CMS, in effect, will aid private industry in solving the problem of patient matching nationwide. And we'll see what form that takes. There are many options, including biometrics. I personally am a fan of that. But as well, there is referential matching. The idea is not just name, gender, date of birth, but things we know about you from property tax or vehicle registration records. I think we talked about this the last time. Anthony, was your first car a Volkswagen? No, it was a Plymouth. Well, I've got the wrong Anthony Guerra, right? So that's referential matching. I use other data about you to figure out who you are. And so biometrics, referential matching, these are the sorts of things CMS will encourage private industry to develop. And we'll get to the point where, with CMS support, we have a nationwide strategy for patient matching. And then through CIMI, through the Center for Innovation, CMS is going to encourage grants and studies to look at novel ways to encourage interoperability. We'll talk in a moment about something that Apple is doing with CVS and Aetna. But you can imagine there are lots of different ways to encourage data exchange in this country that aren't just health information networks or something in the past, something that might involve phones and patients and families. And so, the Centers for Innovation at CMS will encourage the exploration of these new ideas with grants. And potentially, once we see a new idea promulgated in a given healthcare system, then it would be disseminated with CMS help. So let's take a look at the next slide, which gives you a graphical presentation of what CMS is saying. And this is Seema Verma has been very passionate about ensuring patients get easy access to their data. So you'll see on this slide the My Healthy Data initiative, ensuring that patients via APIs can access their full records from providers, and the Blue Button 2.0 notion that claims from payer organizations will get to patients. And so we can see on this roadmap that the first thing they're going to do, we talked about the provider directory with electronic endpoints, and then the healthcare claims being made available through open APIs, and the Innovation Center working on new models of interoperability, and that payers will have to participate in trust networks so that there are clear policies for data exchange, and that they're part of not just a silo of data, but a community of data exchange. And then the public reporting and the shaming of those who don't provide electronic addresses, and then ADT notification, and then benefits coordination for dual eligibles out in 2022. So you can see, the dates there, based on the amount of workflow change, are actually fairly aggressive. And so my experience with government is they say, if you ask for the moon, you'll never get to Mars. So better to start with Mars and compromise by saying the moon is okay. So that's why I think they've set these somewhat aggressive dates, and they may be revised, but better to start aggressive. Let's go to the next slide on innovations to watch. So what are some of the things, given these CMS and ONC regulations, given that Commonwealth and care equality are getting more and more traction, that we're going to see? So first, a few weeks ago, Aetna, CVS, and Apple announced a collaboration on a new app called Attain. What's revolutionary about that? So Aetna said, we think that if we give Apple Watches to every one of our members and ask for patient consent to pool data, that we'll learn a lot about wellness behavior, and that we could tailor alerts and reminders and supports to you with the concept that if we keep you healthy in your home, your total cost of medical expense will actually be less. It'll more than pay for the watch. And so let's use an example. So we have two of my close friends on this call today. We got Anthony and we got Kate. So it turns out Anthony, as a male, what's going to influence his behavior? Peer shaming. I made this up, of course, Anthony. But let's say that you have an Apple Watch and that we are watching your activity, and usually you walk 5,000 steps a day. I didn't say 10,000 because 5,000 may be the right number for you, right? Personalized. Mm-hmm. But then you start, sitting in front of the TV watching Oprah reruns, and you're not doing your 5,000 steps, right? If suddenly we are saying to maybe your associates for which you've opted in to be a fitness coordination group, motivate this guy. He's not walking as much as you should. That works for you. Now let's imagine Kate as a care navigator for her household. She's motivated by coupons. Again, making this up, Kate, so that we can see on her Apple Watch that she's driving by a CVS but hasn't filled her medications, and we're going to give her a 10% off today only coupon. I've completely made up those examples, but you illustrate how if you opt in and agree to send data about your activities of daily living to a machine learning-based system, that we could potentially customize motivators for you to keep you compliant with your care plan, your exercise plan, your diet plan, your lifestyle, all these other things. And so that's sort of the bold idea here. It's using the patient's consent, which is really outside HIPAA per se, right? Because we're not dealing with a covered entity or a business associate exactly here. The patients are saying, yes, I actually want to be part of a wellness community, and I'm going to agree to voluntarily submit my anonymized aggregated data to help train machine learning tools to motivate people like me better. We'll learn a lot. Who will opt in? Will it provide value? Will it actually pay for all these Apple Watches? To be determined. So this spring, we'll see the launch of this Attain app. The American Society of Clinical Oncologists, working with the Joe Biden cancer moonshot, recognizes there's a problem on the road to personalized medicine and precision medicine. And that is for those of us who have had family members with cancer. Remember, my wife had breast cancer in December of 2011. We know that there's just not a huge amount of structured data available today in our electronic health record to deliver precise cancer treatment. Much of the data is buried in notes as unstructured text. And so wouldn't it be better if we had in our EHRs a capacity to gather structured data about cancer care and a universal standard of the data elements needed to deliver personalized and precision cancer care available from an API in every EHR? So what has been launched with the American Society of Clinical Oncologists and Joe Biden and the MITRE Corporation is an initiative called M-Code, or the Minimal Clinical Oncology Data Set that would be used for the coordination of care and machine learning. And so that initiative will play out in 2019. I'll be involved as one of the conveners and facilitators of it, and I hope the end product will be the 100 or so data elements that we will need for care coordination of cancer, and those will be created as a FHIR extension using this new FHIR, what's called R4 normative standard. It will be, in the meantime, before it's balloted as a national approved standard, it will be piloted, and we will validate that it's useful for purpose as a API extension to the existing Argonaut work. That's exciting stuff. Google and Amazon, as you know, are building lots of tools for machine learning. And it's frightening. And I can sometimes meet 16-year-olds who say, oh, yes, I built a machine learning application using these cloud-hosted tools over a weekend. This used to be really hard. And now with these cloud-hosted tools, it becomes much easier. So as an ad you saw 2 weeks ago, but Amazon announced that Beth Lahey is serving as a learning laboratory for Amazon. And they gave us philanthropic support. It is not about creating a product or licensing intellectual property. It's truly a philanthropic effort to ask, how can machine learning work in a real-world healthcare system given the data flaws we know we all have, right? Because healthcare data is very messy. Healthcare data can be biased. And we have to really learn a lot through testing in the real world. If we've treated, let's imagine we've treated patients named Anthony poorly in the past, well, then if we build a machine learning model, we'll treat them poorly in the future, right? So we better figure out what works and not works, where there's bias, where there's error, and refine for the country our approach to machine learning. So Google and Amazon are working hard on that. In the 800 pages of the ONC regulations, you're going to find, it's a somewhat dense discussion of a concept called ARCH. Now, what is ARCH? It is the API, or Application Program Interface, resource collection for healthcare. Now, what is that? Well, publishing just an API isn't really completely sufficient for the easy access of patient data by a novel entrepreneurial cloud-hosted service or mobile app. You're going to need to do things like, how do I register my app so that we deem it secure enough and appropriate for access to data? And then how does it get appropriate credentials to get access to data? There's a whole variety of services surrounding the just generic FHIR API that you're going to need. So in this document, ONC talks about creating a certification rule so that EHR vendors would create an ecosystem that enables apps to be registered and get access rights and record consent and all these other things before data flows. And that's really great, I think, because as we found with Meaningful Use Stage 1 and 2, just publishing a standard doesn't imply adoption. You need the supportive services like provider directories and consent and such things. So ONC is going to be working hard on the certification of API ecosystems that truly will eventually lead to an app store that all of us as patients can use of approved apps to get access to our data. And then, as I said, CMS is very, very interested in patient-mediated data exchange so that if I gather my data and maybe I use Apple Health Kit or maybe I use a novel app, but then I want to share it with a clinical trial or clinical research registry, I should be able to do that very easily. And so instead of waiting for health information networks, health information exchange to be widely adopted by everyone everywhere, tomorrow you could literally say, hey, patient, share the data if you want. It's totally up to you. It's outside HIPAA. It's a lot easier to overcome the heterogeneity of privacy regulations we have in this country. So watch patient-mediated data exchange as a really important idea. The next slide, the blockchain update. So we've talked in the past about blockchain having a narrow set of use cases where it's truly necessary, right? So Graham Grieve, my friend who invented the FHIR standard, has a beautiful slide. It's a decision analytics slide. You know, you've seen these, Anthony. It's flow charts of triangles and boxes and arrows that help answer what do you do in a certain circumstance, yes or no questions are then leading to a new box. And well, his flow chart says this: do you need blockchain? No. Pretty simple, right? And I don't get, quite that dogmatic. What I would say is there are going to be really useful uses of blockchain in healthcare. For example, Synaptic Network Alliance, it's United and Optum and Humana and others are working busily on a provider directory that's blockchain-based, where sources of truth are added by your medical school or your residency or your hospital to a public ledger, where then insurance companies just get the data from the trusted source through the public ledger, and you don't have to spend vast amounts of energy as we do today maintaining thousands of siloed provider directories. So I think it's a great initiative, definitely worth checking out. Blockchain might also be used to solve some of our consent problems. And so right now, Anthony, I actually just left a meeting of the Massachusetts stakeholders working through health information network consent issues. Because right now our consents are all stored in individual provider offices or hospitals. What if we used a public ledger to enumerate our consent preferences, and instead of having to re-consent a patient at every visit, we were able to look to that public ledger source, see the patient consent, and respect their consent preferences. And finally, blockchain I still think is a great tool for data integrity checking. I spend a lot of time traveling internationally, and yes, there are governments throughout the world that are not very trustworthy. I didn't mention ours. But let's just say that there are governments for which you wonder, is my healthcare data is stored by government complete, or has it been altered or changed or deleted? And blockchain as a mechanism of hashing data and persisting that data enables one to go back and say, oh, yes, I look at my data today, I look at the data 10 years ago. I can see through the use of this blockchain cryptographing hashing approach that my data hasn't been altered. So this data integrity concept, whether it's for patient care or clinical trial notebooks or clinical research, to ensure that there was no over time degradation of data quality or integrity is a use case. So I mention these three use cases because I'm seeing a lot of startup companies focusing on these three particular issues. So yes, 2018 led us to think blockchain was a little bit suspicious because people lost their shirts on cryptocurrencies. But 2019 and going forward, watch for startups working in these three areas as getting some traction. And yes, blockchain is an appropriate technology for these particular use cases. Well, Anthony, let's just go to the last slide, questions, and always happy to engage in a dialogue with your folks on your webinar, because that's where the funnest part of this whole session is every quarter.
Well, hopefully we can get some good fun going today. So please send in your questions in the Q&A box, and we will get those in front of Dr. Halamka. Well, let me get us started. Let's talk a little bit more about this continuum of care you mentioned and having to provide information, ADT information, from every patient that leaves your hospital along the continuum of care. How do you define that continuum of care? Is it defined differently for each patient based on who they see? Can it get unwieldy, or do you see this being fairly simple in terms of satisfying this requirement?
Sure. So there are a number of companies that offer this service already. And how do they do it? It's publication subscription. So the idea is this. Let's imagine, as I said, Anthony, you're one of my risk patients in a value-based purchasing contract. So I really care about tracking you. And so I subscribe to you. And therefore, any time you visit any other place in the community, because we've created either a vendor is doing this for us or there is a local health information exchange or network doing it, you're on my subscription list, and therefore I receive notifications about you. And if for some reason you left my organization, I could unsubscribe from you. So that approach, and there are companies like Patient Ping and Collective Medical Technologies, Massachusetts CF Collaborative, and others that offer this as a pub-sub type service. In the case of Massachusetts, certainly we have thought long and hard about this and have really made sure our regulations in the state are already in good shape to support this kind of effort.
Very good. You mentioned this wall of shame concept if you don't put in your sort of electronic address. Do you think that'll work? I mean, that has to, in order for that to work, the wall has to be something that people would actually look at and find, and then it would have to be something that the entities who were put on it cared about being on it and didn't want to be on it. Do you see all that happening and this having an effect? Does this kind of thing ever not work?
Sure, and you're correct that there are going to be exceptions. So in Boston, it's a pretty small community, and boards are very, very sensitive to the reputation of the institution. So let's imagine that the Joint Commission found a flaw, or some industry organization gave you a poor grade because they don't feel like you are performing at the level that's expected. I'll tell you, our boards take that really, really seriously. So hospitals certainly, specialty groups certainly, but you point out, what if there's a solo practitioner who doesn't even accept Medicare or Medicaid, is fee-for-service using cash only? Maybe they'll say, don't care.
Right.
But, think about how many organizations in this country accept Medicare or Medicaid as part of their lifeblood. That's a lot. And most of those organizations have boards that do care about reputation.
All right. What do you anticipate the response of independent, and maybe you just answered this, what do you anticipate the response of independent officers and specialists who don't currently spend time on a direct address to the public shaming? Oh, yeah, you just answered that, correct?
Yeah. So I mean, let's make this completely up. Imagine you are a super subspecialist. You are an orthopedist who only works on right shoulders, and it's an all-cash business. Well, then, let's imagine you're not going to have any financial relationship to anything CMS does, and this may not be your highest priority, so yes, you may not participate. But there is an interesting element to this, to be honest. At least what we're seeing in Massachusetts, even the privates who don't necessarily have a lot of Medicare, Medicaid business, still have an ecosystem of referrers to their practice. And what I am hearing from our primary care docs is if I can't have an electronic way of getting data to and from a specialist, I will stop referring to that specialist. So the shame is one thing, sure, but your referrals are drying up because we can't reach you. That's a pretty powerful motivator.
Very good. You talked about being able to charge only to recoup development costs if you are a developer or an API or this type of thing. Do you see the potential of people playing games with that and inflating those development costs? And, if you tell them they can't make money one way, they're going to figure out how to make it another way. Do you see that being sort of a loophole?
Yeah, of course. But people always try to game the system, right? I mean, that's inevitably. You remember back when, let's imagine Medicare said that it would pay doctors more if they were in an office that was owned by the hospital.
Right.
And the reason that was originally promulgated was because it's true, hospitals actually have more significant licensing and review requirements. It is actually more expensive to operate a doctor's office inside a hospital. So then what hospitals started doing, they started buying community practices. Mm-hmm. And they did it because they knew the reimbursement could be higher, even though the cost of that community practice didn't necessarily go up. So yeah, you start to see this funny behavior when you get these perverse incentives. So could somebody claim, well, it cost me $500,000 to develop the interface, but now every time I install it, it's another $100,000, and how are you going to prove that's false? All I can say is that by promulgating this rule, it's going to be harder and harder for a vendor to justify unreasonable interfacing costs. Because I have seen this, as I'm sure you have, is a vendor has a fixed cost, but then keeps charging every new customer a very substantial sum for something that has already been long paid for. That will be harder to do just because people will be aware of this regulation and would try potentially whistleblowing, so to speak.
Right. All right, next question. Is there anything in the ONC interoperability rule that requires health systems to share EHR data electronically with independent physician groups to integrate into their own practice management systems?
Boy, this is a brilliant question and a person who clearly read all 800 pages, because that is not there. And why is it not there? Yes, the API is required, and yes, making that API available to the patient at no cost is required, but it doesn't say, and that API must be connected to every independent practice group, and you must exchange data with them at no cost. It doesn't say that. And I think here's the reason why. So if I were to tell you Seema Verma wants to just get us over the hump of this interoperability problem, who's going to argue against patients getting access to their data? I mean, that's very hard to argue against. HIPAA requires it. It sounds like goodness in apple pie. So that API will get in place, covered by the notion that everybody supports patients accessing their data. And then once it's in place, you'd think a logical next step is to then say, and by the way, we'll use the same API for provider-provider data exchange. But if we start with requiring what that question really implies, is that every provider must get access to data from every other provider, there's going to be a lot of consternation from the AMA and the AHA and lots of technology expense and concern, which could defer or paralyze the effort. So that's why I think it's missing for the moment. Okay,
very good. You mentioned that HHS and CMS are always been or are now allowed to convene discussions about patient matching and referential matching and figuring out the patient identity problem. What do you see CMS actually doing, like having conferences and things like that? I mean, haven't there been conferences? What can they do beyond facilitating conversation that perhaps has already been facilitated? What do you see happening?
Sure. So the way that, and it's worth reading the CMS rule to see their actual language. They're actually quite clear. They say we can't pay for the development of a universal patient identifier. We can't pay for technology. But we can encourage, we can convene, we can communicate, we can empower private industry to do it. So I think this is, as I said, it's a bit of a sleight of hand way of getting around what was a previous restriction. And
Let me give you kind of an absurd example of this. In the past, when I was involved with the Bush administration and the Obama administration, and we wanted to hold a meeting and we wanted to talk about the patient matching problem, I was actually told, oh, I'm sorry, the government is renting the room, and therefore your having the meeting in that room would be us funding a patient matching effort. And so we actually couldn't. I mean, we literally have to go out to a Starbucks, to have these discussions. And so with this new interpretation, it's trying to adhere to the spirit of what was stated previously, but still move us forward. So I think the government will be a more activist communicator, convener, and enabler than it has in the past.
Very good. Next question. Is this the beginning of the end for the transaction-focused RIO or HIE?
Wow, what a good question. So as we start to think of what's happening today, well, a couple of trends. So we have the idea that patients can get access to their data and can put data from all their providers into one container, as you can with Apple HealthKit. You have the idea that Care Equality has promulgated a set of data governance rules for which, if everybody adheres to these rules, there's trust, and Commonwealth providing some services that make it technologically easier to do data exchange. So if you have patient-mediated data, Care Equality, and Commonwealth, you really need a RIO. The answer is you probably don't. And, if there is a RIO, maybe it's providing some other value-added service like data analytics, quality reporting, or something like that, because just the basics of shipping data from point to point will, in the not-so-distant future, no longer require a thing called a RIO.
All right, very good. Next question, maybe our last, unless we get another one in from the audience. Based on, the regulation, the proposed regulation that we've been discussing, and if you were a CIO, which you are no longer, if you were a CIO out there at a health system, would you say you're going to see probably 90% come through, maybe 10% adjusted, we don't know what 10%, although you mentioned timelines. Would you be adjusting your sort of 3-year strategic plan? I know we don't know what that plan was in my scenario, but would what you think would be a typical sort of approach to the next 3 years, is that change? Would you suggest people move a little to the left, a little to the right, based on what's come out?
Sure. And so I have already adjusted my plan. And that is, as I said, as of March 1st, I became this innovation lead. But, prior to that, we said we really need to redouble our efforts on APIs. And we really need, by September 1st of 2019, to have in production the APIs that are necessary to meet the spirit of promoting interoperability program, but also these new NPRMs that have been promulgated. So, sure, I recommend every CIO in the country to ask the question, does your EHR have these APIs? Do you have the workflow in place to support apps that are patient-facing accessing those APIs? If not, you better get it on the plan.
All right. Well, I think that is about all we had time for today. Another great policy update, and as you said, Dr. Halamka, this is the gift that keeps on giving. So I'm sure we'll be back here in 3 months to discuss the latest happenings. When you close out your WebEx window, you're going to be taken to a post-event survey. If you want to take a minute, we'd appreciate that. To answer it, regarding continuing education, attending our events gets you 1 CEU towards the CHIME CHCIO program. So let CHIME know you were here, and if you've asked us to do so, we will. Do you need a certificate of attendance for another CEU program? You can use the final slide in this deck. You'll receive an email when the archive recording of this event has been posted to YouTube. And you can reach out to Nancy Wilcox if you would like us to produce a webinar on the topic of your choice, and of course go to our website to see our upcoming schedule. So with that, I want to thank our good friend Dr. John Halamka for his informative and entertaining presentations, and I want to thank you for attending our events. And with that, everybody have a wonderful day. Thank you.
Thank you.